noon ethics lecture this afternoon, and I also want to thank the UCLA Law School for co-sponsoring this talk. So thank you very much, and we actually have some of the students and professors in attendance with us. I'm Catherine Brown-Saltzman. I'm co-director of the Ethics Center here, and we are delighted that you're joining us this afternoon. Let me take a moment and introduce our speaker. Professor Rebecca Dresser is an expert in biomedical ethics. She holds a joint appointment with the Washington University School of Medicine, teaching law and medical students about legal and ethical issues in end-of-life care, biomedical research, genetics, assisted reproduction, and related topics. She has written extensiviously in her field and is a co-author of a casebook on bioethics and law, and a book on the ethical treatment of animals. She is also the author of a book on patient advocacy and research ethics. In addition to her teaching, research, and scholarship, she is an advisory and editorial board of several prestigious journals devoted to bioethics. A past member of the President's Council on Bioethics, she currently sits on the Washington University Medical Center Institutional Review Board, as well as the Embryonic Stem Cell Research Oversight Committee. And Professor Dresser is a prolific speaker and panelist at national and international conferences, symposium, and workshops on such topics as bioethics and cancer, advanced treatment directives, stem cell research, biomedical research policy, and human cloning. Before becoming a law professor, she clerked for the Honorary James Doyle, the U.S. District Court for the Western District of Wisconsin, and held a postdoctoral fellowship in psychiatry department at the University of Wisconsin-Madison. So we welcome you, Professor Dresser, who is presenting When Patients Make Bad Choices, Complexity in Decision-Making. Thank you.
Thank you. Hello, thank you for coming. I appreciate your interest. I am going to talk today about ethics and patient decision-making. There are plenty of seats up here in front. You're just like law students. You always want to sit in the back. A decision that I made as a cancer patient. This is why I can label it a bad decision, because I made it, so I'm not being too judgmental. So I developed this presentation in connection with a project I was involved in. I had cancer. I was diagnosed just about 10 years ago this week, and I'm one of the lucky ones who survived. And while I was sick, I was sort of in the halfway state of not feeling so terrible. I was just sleeping all the time, but not really being able to do much either. And so I would lie in bed and read the New York Times and listen to NPR. And I heard a story come on about a couple of cancer doctors who had had cancer and what they learned about their field from their experience. And I was lying there and I thought, hey, we could do this in ethics. So after I got better and got back to work, I knew of other people in the field who had had cancer or cared for a spouse with it. And we got a grant to work on a project about what we had learned about our field from our personal experience. So we ended up producing a book called Malignant: Medical Ethicists Confront Cancer. It came out in 2012. And every chapter, it's breaking bad news and sort of the standard topics, and then also the ethics of being a family caregiver, the ethics of support groups, facing mortality, dealing with all the wonderful and unintentionally hurtful things that people you know say to you, like, oh, this is going to be a wonderful journey and you'll learn a lot, like, be quiet. So we tried to kind of expand the notion of cancer ethics beyond the standard topics. And each chapter begins with the story by one group member that had a particularly vivid experience associated with this topic. So the story I'm going to tell involves treatment decision-making. So this is about a treatment decision I faced in the middle of treatment. When you're a cancer patient, you're first diagnosed, you have to figure out, well, what treatment regimen do I want, if any? And then once you start treatment, a number of other decisions come up as you're going through chemo or radiation, whatever. You have to think about how much pain medication to take, whether to go into the hospital, whether to stop a treatment because the side effects have gotten so burdensome. All sorts of, so the decision-making doesn't end. So I had head and neck cancer, and I had chemotherapy and then radiation and a combination chemo-radiation, which is awful, and I hope none of you ever have to go through it. But before the radiation phase, one of my radiation oncologist and a resident sat down and sort of went over what was going to happen. And they showed me slides. They were trying to get informed consent to sort of illustrate what would happen and the side effects and so forth. They told me that mouth sores and other radiation side effects would make it hard to eat and swallow, and that about half the patients going through this ended up having a gastrostomy feeding tube for adequate nutrition. They showed me PowerPoint slides, and one slide was of a patient with his face concealed, but he had a feeding tube in his stomach, and to show me what it would look like. And I remember thinking, well, that guy looks like he needs to lose weight. Why does he have a feeding tube? This is the kind of thing that patients think about while you're going through the information for informed consent. They're thinking about stuff that's not even relevant. But anyway, so I saw what it would look like, and by the time I was starting radiation, I was already a lot thinner than that patient. I'd lost some weight because of the tumor making it hard to eat and swallow. It was painful. And then the chemotherapy I had already had made it hard to keep down what I could eat. But I was determined I was not going to have this feeding tube. To me, I had actually written about medical nutrition, the law and ethics of it, and that was all end-of-life stuff. That was stuff about Terry Schiavo and patients in a persistent vegetative state, or patients with advanced dementia, that kind of thing. And I didn't want to belong to that group of patients. Also, I had other reasons before my diagnosis. I'd been kind of a health nut. I exercised all the time and had a healthy diet, and so I thought I was tough, and I wanted to show everyone that I wasn't one of the spineless patients who would need this kind of help. I was also an overachiever, the Lake Wobegon effect. I wasn't going to be part of the bottom half, as I saw it, of any group that I belonged to. And then also control over my body and my life were significant factors. I think I already had a port in my body, this foreign object for chemo and blood draws and all that. And then this tube would be another unwanted physical mutilation, as I saw it. Treatment sessions, doctor appointments, and medication schedules had taken over so much of my life. But eating and drinking were still things that I could control. And I didn't want to hand over one more ordinary life activity to the world of medicine. Also, to get this tube, I'd have to be in the hospital a few days. At least at that time. I understand that that's not necessarily true now, but I didn't want to go in the hospital from all my teaching and so forth. I knew that hospitals were dangerous places. You might get an infection. You might become the victim of a medical mistake. So I didn't want to go in there. Also, I didn't want to be deprived of the security of my home. I didn't want to be stuck in a room with a stranger, with a loud television and all of that. And then it's possible that chemobrain, which you may have heard people talking about, I don't know how much it's established by evidence, but people say being on chemo, their mind feels kind of fuzzy. That might have had something to do with it. And then I was on pain and anti-anxiety drugs as well to help me deal with the treatment. So maybe that had something to do with it. But just to be frank and honest, I think it was mainly my stubbornness and pride that led me to this decision. When you get seriously ill, you don't turn into some saintly person, at least the people I know and I know myself. I did not. You still have the same personality characteristics, some of which are flaws, that you had before. And some people, in fact, get even more, have even more sort of personality issues. At a bioethics and cancer project group, at one point I said, you have cancer as you. So this was part of having cancer as me. I was being stubborn and prideful. So after a few weeks of combined radiation and chemotherapy, I wasn't doing very well. I was still losing weight. I had an appointment with one of my oncologists, and he said, we can always think about this feeding tube. I was still insisting I didn't want it, so he said, well, we could try some extra IV fluids and do some other things that, the issue was trying to get through the radiation treatment. And once that was over, I could gradually, start eating better. So he said, maybe we can tide you over with these other things. So I said I wanted to try the less drastic option, and he agreed and wrote the orders. So for another 10 days or so, doctors and nurses continued to cooperate with my quest to avoid this tube. But I was still, despite these efforts, I was still losing weight, and the extra fluids were starting to cause swelling and their own side effects. My partner, Peter, was my primary caregiver, and he was going crazy. He wanted me to change my mind, take the tube. But I continued to insist that I knew what was best. I wanted to be independent. But then one day, I could barely get out of bed, and I was very weak. Peter was frightened, and he said, we are going to the cancer center. I don't care what you say, even though I argued with him. So we got there, and he took one of the nurses aside, one of the nurses we'd gotten to know, and one I especially liked. And he said, will you please get her to take this thing? And she took one look at me, and she said, okay. So she came over to me, and she put her face down really close to my face and said, you really need to do this. And so I said, all right. I gave in, and that's how it felt, that I was giving in. But I really also was convinced that this was serious by the look on her face and the look on Peter's face, and I could see that I had got myself into a serious medical situation. So I was admitted to the hospital with a diagnosis of failure to thrive, which was something I had only heard in connection with premature infants, but now that was me. And I did have an annoying roommate with a loud television all day long, and then she had a lot of friends who would come and bring in things like McDonald's, and you can imagine that I did not want to smell that stuff. But so I was not happy, but it wasn't that much worse than the way I felt when I was home. And there were a few irritating glitches in my care, but no major medical mistakes. I did go in right before Memorial Day weekend, and several of us in the group learned that you never want to need medical care on the Friday before a weekend holiday, a 3-day weekend. So the issue was I going to have to stay there till Tuesday to get it put in, or could they do it late Friday? And finally, with a lot of calls and so forth, I got it on Friday. And the people who put it in were very good and totally competent, and I didn't have any problems. And the tube itself proved to be a blessing. I mean, I wasn't crazy about it, but it was really, it did save me. I still had nausea and vomiting, but I was gradually able to take in enough calories to maintain and then gradually start gaining some weight. The tube feeding itself was simple. The tube was easy to hide when I wasn't using it. So if I had accepted the tube earlier, I would have avoided a serious threat to my health and well-being. I had overestimated the burdens and underestimated the benefits. So even though I was a relatively informed patient, I made what I think was a bad decision, at least for a while. So let's look at this sort of from an ethical point of view. The modern medical ethics field emerged right at the time when patients and families were starting to question doctor knows best, medical paternalism, and this tradition. And so medical ethics came in, and we started talking about a new model called shared decision-making. And I'm sure you've heard of this. In this new model, patients would have much more power to determine their treatment. Doctors would continue to apply their expertise by saying, okay, here are the reasonable options. But then patients would decide which option they wanted to choose. So now this is what we teach all the students and talk about all the time in ethics committees and so forth. But it doesn't always live up to the ideal. Nobody really wants to go back to the old days of medical paternalism, but the new regime is also imperfect. So I think that the story I told reveals some of the imperfections. You can look at the story from several angles, which I'm going to do. One way is to look at it as all's well that ends well. The clinicians were very respectful of my autonomy. They allowed me to determine my treatment. And then when my preference became too risky, one of them, the nurse, convinced me to reconsider. Perhaps the decision process didn't go as smoothly or as quickly as one would like, but the basic model of shared decision-making worked in my case. But when I look back at it, I wish I had consented to the tube earlier. By the time I finally did, I was overwhelmed. I said, I'm just going to quit this radiation. I can't take it anymore. And fortunately, Peter and another nurse talked me out of that decision. But I did have to have a brief delay in that. And then also I did get so thin that I had to really work to gain weight. And I had always been a person with watching my weight and so forth. And believe it or not, it's hard to gain weight as it is to lose weight. So that was another sort of negative aspect of this. As far as I know, my decision didn't have any long-term effects, but it did make my recovery longer and harder than it would have been if I had just had this tube. So if shared decision-making fell short here, why did that happen? Well, one possibility is that my capacities were impaired. Maybe I wasn't fully capable of making my own treatment choices at that point. I had a skin patch that was delivering higher and higher doses of fentanyl, which you know can affect people's thinking. I was also, as I said, taking anti-nausea drugs and anti-anxiety drugs to help me sleep. And these definitely affected my mental state. At one point, Peter said it was like I had Alzheimer's. I wasn't remembering things. But I don't think that I ever lacked a basic understanding of the relevant information for informed decisions, the risks, the benefits, and so forth. I think if they had brought in a psychiatrist to talk to me, I think I would have passed the capacity assessment. So I think a better way to describe what I was doing was making an irrational yet competent medical choice. So one of the people in our cancer and bioethics group was Dan Block, ethicist at Harvard. And a long time ago, he wrote an article in the New England Journal about 3 forms of irrational thinking that can affect competent patients' decisions. In these cases, patients may choose a treatment that fails to promote their long-term values and goals or overall values and goals as effectively as a different treatment option would. So one form of irrational thinking is when patients refuse a burdensome intervention that will prevent later more serious burdens. So I think I was making this kind of choice when I was refusing the tube. I was just obsessed about the burdens of this tube. And I just wanted these doctors to leave me alone. But in the process, I was exposing myself to more harm with the dehydration, the weight loss, and a premature end to my cancer treatment. My overall goal was to get through this and try to live, obviously. So I lost sight of my big picture goal. Another phenomenon that can lead to irrational decisions is denial. I'm sure you're familiar with that. And I'm not totally anti-denial because as we write in our book, you can't get through this stuff without a level of denial. Some days you just don't want to hear about the burdens or the risks, But obviously denial can be bad too. There are people who can sort of engage in a form of magical thinking, refusing to recognize the risks presented by the decisions they're making. So I think that my persistent belief that I could get through this without this tube was a form of denial. I just wasn't really accepting what was happening to me. And then finally, fear is another factor that can contribute. In this New England Journal article, they write about some patients who just had this irrational fear of a procedure. They even said, well, I want to have this, but I'm just too scared. I don't think I was in that category, but I do think I had kind of an irrational aversion to the idea of getting this tube, having this thing in my body, and having to be in the hospital. The fantasy that I had about this tube was much worse than the reality. So for you all, the question is, what should clinicians do when you have a patient who seems to be under the influence of these kinds of irrational ways of thinking? So in the article, Dan and his co-author said, well, first of all, you have to be watching for it because it's not always clear that that's going on. Somehow I was able to fool my doctors that I was just being autonomous and independent. They didn't really see maybe in depth what was going on in my mind. So you have to be watching for it. And that you should speak out when you think patients are choosing irrationally. In my case, somebody finally did speak out, the nurse, but it took a pretty long time. So why did this happen? There's a famous ethicist and law person, Jay Katz, who wrote a very well-known book called The Silent World of Doctor and Patient. He was actually a psychoanalyst. And he was a very big fan of shared decision-making, but he also knew and admitted all the things that can get in the way of achieving it. So one thing he talked about was the way that patients and physicians are uncomfortable with the kind of discussion that shared decision-making can require. You have to engage in what he called probing conversation, in which conflict is inevitable. And I don't know about you, but I know as a patient and the doctors I know aren't exactly interested in getting into arguments. But I think sometimes they should. And I actually had a little piece in the Times called "Sometimes Doctors Should Argue with Patients." And I also said patients should sometimes argue with doctors. But this is not something that we teach our students to get comfortable with. He called it the give and take so necessary for joint decision-making. I think, obviously this isn't a tradition. It's hard enough to kind of teach about how do you give information in a way that patients might begin to understand it, and then getting to the point, well, what if the patient's doing something that you think is kind of strange? How do you deal with that? So I don't think we do enough to talk about these real dimensions of what shared decision-making can involve. It doesn't always, but it can. I think my doctors didn't want to confront me. It might have been because I worked in the med school, and maybe they gave me more deference than other patients. Maybe they were more hesitant to raise questions about my choice. It was kind of humorous that in our group there were a couple doctor ethicists as well as we were all very experienced teaching this stuff, and we seemed to be treated as honorary doctors, we said when we were patients. Whereas we sort of had more respect, and doctors sort of assumed that we knew more and didn't need as much help as the ordinary patient. But even the doctors in our group said, we needed just as much help as any other patient. When you're sick, it's very different, I'll tell you. And you may know the famous article by Franz Engelfinger, who was the editor of the New England Journal, when he became a patient. And he had the same, I think it was esophageal cancer, and that was his expertise. And he got all this information from his friends and everything. You should do this, you should do this. And he was just at his wit's end, and somebody finally said, you know what you need? You need a doctor. So this is something that we all experienced, and it may happen to you as well when you're a patient. In any event, I think that was just sort of deference was part of it. Also, the fragmented structure of medical care in a good place like this, and where I was being treated. The system is so, everybody's doing their own part. And I was going to the cancer center a lot, but I would be going there, okay, you're here for radiation, so we do the radiation. You're here for chemo, so we do the chemo. And I wasn't seeing, the main clinicians in charge of my care just every few weeks. And so nobody was sort of looking at the big picture in between. And so I crashed in between my visits to the main oncologist. So I think that had something to do with it. Here I was well insured. I was being cared for in a top cancer center, a place where I worked, and people knew of me. I was privileged in all respects, but Peter was the one who had to grab someone and say, will you please look at her and see how badly she's doing. So I think that's kind of a lesson. So what's to be learned from this? Well, what I learned was that I was very unprepared to make a treatment decision like this. Before I got cancer, I'd been teaching and writing about medical ethics, things like autonomy and informed consent, treatment decision-making for more than 2 decades. This was a useful background. It was somewhat helpful, but it wasn't as helpful as I would have thought ahead of time. I knew something about how complicated medical decision-making can be, but making my choices not just here, but about which treatment regimen to have, that were very hard and draining. I think we don't understand the psychological impact of being diagnosed with a life-threatening illness. You're not yourself. And there are some people, for example, Dan Block is a very rational person, and he went on the internet, but he was also very confused because you don't, what you see on the internet. So it's just, you're not your usual self in making decisions. You have, I'm sure, heard by now all the doctors who have written about becoming patients, and they talk about becoming confused and vulnerable. And I know now it can happen to medical ethicists too. When we talk about treatment decision making, it's almost like a mathematical formula. Okay, you learn about the risks and benefits and what it involves, and then you're the patient and you just plug in your values and you come up with the answer. It's not like that. We aren't experts in knowing how to apply our general values and preferences to a specific decision we've never made before. We also may have desires and objectives that are in conflict. So my overall goal, as I said, was to get through this treatment and try to survive. But that was incompatible with refusing the feeding tube. I couldn't have both ways. And that can happen too. Also, I inflated this threat that, how my well-being would be threatened by this tube. I don't think we can really know how we're going to react to an intervention until we actually have it. Now, that doesn't mean I'm saying people can't refuse surgery because they have to have the surgery to see how they'll react. But I do think we should be honest and say, this is how I think I'll react, but since I've never been in that situation, I'm not sure. And that's, what happened to me. I reacted in a different way than I thought I would. Also, it taught me that the physical and psychiatric or psychological burdens of illness and treatment can start to dominate a patient's thinking. This produced a reaction that Paul Applebaum and Lauren Roth wrote about also in a classic article. I give you the citation at the end, in JAMA about, they interviewed a lot of patients who were refusing treatment and, tried to figure out why. And they came up with these different overall broad categories. And so one of the ones they talked about was hospital fatigue syndrome. I bet you've run into this, where these were hospitalized patients who were exhausted by their experiences and desirous, above all, of returning home. They just want to be left alone and they want to go home. Now, I wasn't in the hospital, but the intensive chemo and radiation therapy I was having, I think, produced kind of the same kind of exhaustion, treatment fatigue syndrome, where I just wanted to be left alone. One remedy for that is to leave patients alone for a little bit if you can, and people might get more energy to take on the burdens again. From a broader perspective, I learned that patients' choices emerge from a mix of ingredients, and not all of those ingredients are worthy of unqualified respect. People have values, and then they have values, or preferences and preferences. That some of them are not as significant as others. I think for me, it was a stubbornness and pride that was driving my decision. And in their study of patients who refused treatment, Roth and Applebaum found several patients whose treatment refusals reflected what they called the patient's characterological style of dealing with stress. So when they got in a stressful situation, they became obstinate. And I think that that's probably true of me. It's part of my authentic self, but it's not my better self. So, you might think about what I was doing as my desire for independence, and that sounds all very, valuable and morally significant stuff, but it was also my stubbornness, which maybe isn't so valuable and morally significant. So it's more complicated than I appreciated before about values and preferences. So I think there are lessons for patients and clinicians. So what are the lessons for patients? And by the way, as well as family caregivers, by the way, you're going to be those too. So just because you're clinicians doesn't mean you can ignore this stuff. One of them is that patient autonomy can be a challenging business. Even the most educated and savvy patients facing serious medical decisions may not be very good at it. I think patients should recognize that they're not experts on this particular decision that they're faced with and be more receptive than I was to what clinicians have to say. You probably like that, right? I think that clinicians obviously may not have the same individual values a patient has, but I've seen many other patients, and I think the way to frame this stuff, some of it is to talk about, I've had some patients who initially didn't. In fact, after this was all over, I gave copies of this book to my chemo-oncologist and my radiation oncologist, and my radiation oncologist said, patients usually fall into three categories with this feeding tube. There's one group who just are preemptive. They say, just give it to me now. I want to get it in case I need it. And then there's a middle group, they play it by ear, and then, at some point they say, okay, I think I need it. And then there are the ones, the stubborn ones, the ones who are really resistant, and you were in that group. I think that you all have this, I think framing it in a way that other patients with different values and preferences have thought about this treatment option can be very helpful. And, I think I wish I had been more receptive to that kind of information. I wish I had heard more about it. In fact, something like talking to another patient who had a feeding tube would also have been, I think, quite helpful. So anyway, the way I see it is also that patients should listen to people like Peter, loved ones, even though we have a chapter in the book on the ethics of being a family caregiver, and you often do get into these struggles, and as a caregiver you get frustrated with the patient, and it's very challenging. But I think for patients, you have to realize these are people who know you well, and they know your values and preferences, and they know what you want, and you should at least listen to their opinion and be receptive to it. So that was another thing I learned. And then I think that for clinicians, the advice is you should respond actively when patients are making decisions that just don't quite make sense. There's nothing wrong with saying, well, help me understand why this is your choice. And I don't think there's anything wrong with a little bit of argument or persuasion. If the patient is making what seems to be an irrational choice in the way that I talked about earlier, that is, well, you want the treatment, but you don't want to do what you need to get through the treatment. I'm having trouble understanding that. How far to go with this is hard and delicate. I don't think anything in what happened to me or anybody else, in the book we have some other examples of sort of push-pull between patients and doctors. None of it is saying, well, let's go back to medical paternalism. None of it is saying you should coerce somebody to have a treatment, either physically or deceive them or something to get them to do something. But I think persuasion and argument can be fine. When you think about when we have disagreements in everyday life with the people we live with and people we work with, don't we argue and persuade? That's part of reaching a good decision. I think that can be appropriate in the doctor-patient situation or nurse-clinician-patient situation too. Also, I think that this is a reminder that medical decision-making occurs over time. So I think the choice that I made initially not to have the tube was fine. Before the radiation started having the side effects and so forth, no problem. But often it's important to revisit an earlier treatment choice. So I think it's very important for y'all to come back to something and say, okay, well, here's what the facts were initially, but now they've changed some. So maybe you want to think about a different balancing than you did initially. Nobody really did that in a very direct way, and I think that if a doctor or somebody had said, you're starting to have some real physical effects of not having this tube, of not getting enough nutrition and hydration, and that's making your health precarious, and you might not be able to get through treatment with this. I might have knuckled under sooner. So I think that doctors and clinicians should bring things up again, and patients should feel free to revise an earlier choice. And you all should say, I've had lots of patients change their mind. There's nothing unusual about it. So if you feel like you want to, you ought to. So, as I said, I don't think my feeding tube story supports a return to paternalism, but I do think it shows that the shared decision-making is harder than many of us realize. It's easier said than done. And fragmentation of medical care today makes it more challenging. Before I had cancer, I didn't understand how hard it can be for patients to figure out the best way to exercise their decision-making authority. And I didn't understand how much patients can benefit from listening to the people involved in their care. As a cancer patient, I wasn't this isolated individual expressing a set of fully formed, pre-existing preferences, but I was really more like a student learning how to go about a new activity. I'd been lucky. I'd never had to make a serious medical decision before. I'd never been seriously ill before. So that's a model I think that we ought to talk about more in ethics. Also, I thought I knew facts, but my information was imperfect and incomplete about feeding tubes. So I needed to be more open to, feeding tubes can be temporary. It's just something you need for a little while. It doesn't mean that, you're going to be attached to this forever. Although I did have that possibility with my cancer, which was quite frightening, and I'm happy I didn't end up with that. So if I remain capable, the next time I have to make serious medical decisions, I hope that I will be more engaged with others as I search for the right thing to do. And that's the end. These are my citations. Thank you. So we have some time for questions and comments and arguments. You can argue with me if you want. I'll start with you, sir. Go ahead.
Thanks. That was really interesting.
Thank you.
I guess the question is, were you capable?
Uh-huh.
Or were you failing to appreciate
Yeah.
the circumstances? And I guess I have two questions. One is, what should the doctors have done if you had continued to fail and then moved on to a point where you were clearly incapable and would likely die?
And then Peter would be my surrogate, and he would say, give it to her.
Oh, but Peter shouldn't be able to override your choice.
My previous wishes, yeah.
So should the doctors have let you die, I guess, is one question. But I think a more difficult question, something that we face, is should the doctors have offered you or been willing to use a less good treatment, a more dangerous treatment, like intravenous therapy, at the time that you were refusing to use your intestines, which is the preferred method?
Uh-huh. Well, I don't think he should have coerced me to have the feeding tube. I think the way he saw it, I was making this autonomous choice, and so this was a way to reconcile what I wanted with my health issues. this issue about, I do think he's a very nice man. I love him. I still see him. I think he was too respectful of me in retrospect. But I understand. In fact, he read this chapter and he wrote me back. He said, I always have trouble. I try to, based on, of course, as oncologists, you don't know patients until you meet them when they're very sick. He didn't know me that well. I'd seen him a few times. He said, I try to feel out what kind of a person they are, how appropriate it is to push and so forth, but sometimes I'm wrong. So I think it probably would have been good if he had pushed me more to sort of say, do you really understand? I don't think I understood that I was jeopardizing my treatment. Maybe, my radiation oncologist later said, you were one of the most stubborn patients I've ever run into. So maybe they did tell me, and in the book we say, we have a caveat, these are the way we remember things. And we did talk to others some to get the bigger picture, but I might have been wrong that they didn't push me, or at least I don't remember them pushing me very much. But anyway, I think he could have coaxed and tried to persuade and sort of said, realize what's going on here now. I don't think he should have ordered me to get the tube. I guess he could have said, I don't know if I'm going to cooperate with your chemo anymore unless you do this. I don't know that would have been appropriate. This issue of what if I had become clearly incapable, this is an area of interest of mine about how valid are advanced decisions. So if I were incompetent and Peter had the choice, it would have been clear that my values and preferences were not to have the tube, but it was also clear that my values and preferences were to get through treatment. So I think you might be able to make a reasonable argument that the patient's overall preferences, more important preferences, would be to have the tube. As far as whether they should let me die, I don't know. That's a very I don't know. I guess I don't think they should have allowed me to die. But that really is how far you're going to take patient autonomy. Let's say I really was exercising my best values and preferences. It just seemed a very irrational decision to me. So I would hope that it would be interrupted at some point. Yes, sir?
My question is along the same line, and my reflection is, I think we frequently get in our trying so hard to preserve autonomy that sometimes we present the menu wrong.
Uh-huh.
And if they had put the two things together, one of your choices is to have chemo and radiation, but that will entail a feeding tube, and then your other choice is hospice or whatever your choices actually were, to not give you quite so much autonomy, wouldn't that have taken a big burden off of you?
Well, but I guess medically, half the patients don't need it. So I don't think you should say everybody has to have it because half the patients need it. So I don't think that's the easy answer. Sorry. Let's see. How about one of the law students there? Yes, ma'am.
You mentioned that it was your that Peter eventually intervened, and that you would have also maybe benefited from.
I'm sorry, I can't hear you very well.
You mentioned that it was Peter who was
Yes,
intervened, and that you would have also benefited hearing from other patients. So do you
Yes.
think maybe there needs to be more involvement of the family and the community, maybe even at the point where you gave informed consent with the PowerPoint, where you had the PowerPoint presentation? Do you think maybe at that point it should be a wider audience that makes the decision?
Well, I'm not sure I want the community in there, but
Yeah,
I think Peter.
What I mean that is
Sure, that would have been. He didn't happen to be there that day, but I think a lot of people have their spouse or whoever is their primary caregiver in there with them. I think he understood the benefits of the tube better than I did, even though he didn't sit through that thing. It's. I guess I know this is frustrating, but it's hard to generalize. This is just, I think you sort of have to approach all of this with the idea that it's complicated and individuals are different and families are different and people, one thing we talked about in the book was even our own preferences change from day to day. So some days, all we wanted to do was talk about cancer. And so if somebody called us up and started talking about something else, we'd get mad because they're just talking about trivial things. I just want to talk about this serious situation I'm in. Other days, you don't want to hear the word cancer. And somebody brings it up, and then you get mad at them because you don't want to think about it then. I mean, it's just, you know how we are, human nature. I mean, we're sort of crazy that way about other things, and this is the way patients are. So, like in the chapter where we talked about how unintentionally unkind people can be, and this was some people in the medical setting, but it was more people, friends and acquaintances and relatives, co-workers and so forth. People are so uncomfortable. You've seen this. And I'm still uncomfortable when someone I know but not that well is seriously ill. What do I say? And people say the worst things. And so, but we also say in that chapter, we were hard to please because our moods were different, So something that would have been just right one day wasn't right the next day. So I'm afraid I can't give too many formulas. I mean, I think I can give some guidelines and so forth, but I think in the book, one thing we want people to walk away with is, first of all, you can learn a lot from this experience, but it's hard-won knowledge. It breaks your heart. We had a couple people whose spouses died from cancer. So when we met, we orchestrated it. We had different topics, and it was kind of an academic sort of meeting. But then it was also kind of a therapy group. We taped the whole thing and transcribed it, and so it's a really rich discussion. And we used that to put the book together. But it really, we learned a lot from each other. We would talk about how we responded, and somebody else would say, well, that's really strange. I responded a complete different way. So, sorry, but I think trying to learn as much as you can about the patient's individual situation, being open, hearing, let the patient have an opportunity to say where she is. Although we had some negative experiences with clinicians, we came away overall with so much admiration because we now realize how hard a job it is that you have. So anyway, sorry, I'm going on. One last, yes?
I think I'm a psychologist.
Oh.
I think the important thing is physicians in general to have a group, to make sure that they can talk with each other about everything. This is a lovely lecture, wonderful, and so that they can even role play out how to handle something.
Right. One thing that was great for us in this group was, we're sort of treating our own personal cases as medical ethics cases that we're, dissecting. So The other people in the group were more objective, and they could say, "Oh, why did you do this? And did you think about this?" More as the objective person. So that was, I think, very helpful. And you're right. I think the more sort of perspectives you can have, the more you're going to be able to see what's going on. Yes?
You made a very striking analogy, I think, which I hadn't thought of before, which is between the patient and the student.
Uh-huh.
The student being someone who has got to learn to do something which before they are not able to do.
Right.
How might we go about helping patients or potential patients learn how to make good decisions?
Yeah, I think that's a really good point. I also think that clinicians are students in that you're learning about the patient and the family and so forth. Everybody's a student. I've had so many ideas from this whole, all of this stuff. And one is, I often am kind of irritated when I read pieces about, well, this is what a good patient should do. I'm like, how do you know? It's often they're written by clinicians or sort of people who haven't been patients. But I think I would love to get a grant or do a big project with lots of people who have been patients and, clinicians and so forth, and talk about what advice can we give people in our culture about, first of all, you have a culture where nobody wants to talk about serious illness and dying and so forth, so people are unprepared, and they don't know, what it's like to make these decisions. Just a sort of a public education project. I think that would be wonderful. Haven't been able to do it, but I think that would be a really worthwhile endeavor. Okay, I think it's time. Thank you so much. I enjoyed it.
Thank you, Rebecca. And I think the idea of the complexity of this, right, is what you've left us with, and the work that yet needs to be done to address decision-making, which on the one hand seems very straight ahead. And I particularly appreciated the fact that, in a sense, you were a VIP patient,
I was.
right? And that adds just yet another layer of complexity. I want to also extend to the law students and also anybody from the Medical Ethics Committee that would like to join us for a discussion afterwards. We're going to meet just out front. And just a quick reminder that there'll be another ethics lecture next month. You can refer to the UCLA Ethics Center webpage to keep up with our lectures. So thank you again, Rebecca, for your great lecture.
Thank you.
Appreciate it.